Thank you very much for the invitation. Dr. Cameron and I go way back. If I'm doing this today, it's actually because of him, so I'm going to blame everything on him. Bob and I met when he was a fresh faculty and I was a fresh faculty at UCSF. We met on the wards and realized that nobody at UCSF was remotely interested in thoracic malignancies. So 2 decades later, for good or for worse, here we are. So I'm going to touch a little bit upon some of the immunotherapy approaches, and I'm going to finish talking about the CRS-207 vaccine trial, because we've been very involved in that at UCSF and have treated quite a few of those patients. So it's a very interesting story that is just starting to unfold as we speak. So real quickly, mesothelioma, though low in incidence, for all of us who live in port towns and in towns where there had been quite a bit of asbestos-related activity, it is a major, major problem, because while those activities may have ceased and may have ceased a couple of decades ago, their damages persist way beyond the disappearance of these industries. And the prognosis for this disease is still abysmally poor, with a median survival of about 12 months and a 5-year survival that is well below 5%. So clearly there's a lot of work to be done. Dr. Orlevsky showed you this trial already, the granddaddy of them all. This was the trial that really led to the approval of pemetrexed and as a standard of care for mesothelioma. Clearly the backbone of pemetrexed, cisplatin, really is here. At least it's the best game in town, and it takes upon us to try to build on it. This trial had a slight separation in curves. There was about a 3-month median survival, but what was actually very interesting is that not only was there a survival benefit, but there actually was a quality of life benefit that was noticeable in terms of pain management, but also in terms of breathing. And there was some physiologic measurements done to go with this, including increases in FVC, forced vital capacity, for these patients that was actually of significant improvement, and really assisted in why some of these patients did a little bit better than what we would have expected. Since 2003, a lot has been going on, but a lot of disappointments as well. So mesothelioma biology, we know that mesothelioma does induce a really high level of VEGF expression, vascular endothelial growth factor. In fact, when you look at different tumor types, patients with VEGF have the highest circulating levels of VEGF. So patients with mesothelioma have the highest levels of circulating VEGF, which is really makes it seem like it should be an important factor. When you look at the resected specimens, mesothelioma specimens have very large numbers of microvessels, so that angiogenesis really is an important phenomenon for this tumor. So the last decade and a half has seen a lot of activity trying to test all of the molecules that would target the VEGF axis. And you can see from this list, which is really a partial list, that none of these have made a major impact. And it looks like the oral tyrosine kinase inhibitors targeting VEGF may not work as well. The exception to this may be nintedanib, which is undergoing much further evaluation than any of these molecules, because the phase 2 trial was so provocative. When you look also at resected mesothelioma specimens, they tend to stain very intensely by immunohistochemistry for EGFR. When you actually tease that out a little bit further, you don't quite see the same story that you'd see in lung cancer, where you can actually have driver mutations that explain the sensitivity of lung cancer to targeted therapies. Mesothelioma, you never see targeted mutations, so that you do activating mutations, so that you see no activity when you try to target the VEGF axis. The PDGF axis also would seem to be a very good target for mesothelioma. There's a lot of PDGF overexpression, and preferentially the beta part of the gene is more expressed than the alpha, which is more expressed in normal tissues. And yet, targeting it with drugs like imatinib or vitalinib doesn't seem to have as good an effect as you would have expected. So none of these agents really has made it into prime time. So despite this, is there any progress? Dr. Olewski presented the results of the MAPS trial. And the MAPS trial is some progress. There had been an earlier attempt by Dr. Kindler et al. To test the addition of bevacizumab to chemotherapy, but this was, the trial was pre-pemetrexed days, and it was a gemcitabine-based chemotherapy backbone, which is probably not as effective. So Dr. Kindler's trial ended up being negative. It was a smaller trial. It was a consortium trial, so it wasn't just a single institution study, but it still ended up being a negative study. Nonetheless, it had a provocative result that in a unplanned analysis, if you looked at the circulating level of VEGF and were able to devise a cut point between high and low, patients who had low expression of VEGF were the ones who seemed to be responding to bevacizumab, whereas the very high level of VEGF patients did not seem to respond to the addition of bevacizumab. That result has not been tested prospectively. Meanwhile, this trial came along with a better chemotherapy backbone to base the use of bevacizumab on, and indeed it was positive, with an improvement in median survival of about two months or so. Dr. Sturman made a point earlier about whether this trial really was applicable and should serve as the control arm, at least the active arm in this trial should serve as the control for future studies, and that certainly is something that is being considered in a number of trials. The problem has to do with the use of bevacizumab in elderly patients. It's very difficult in people over 70 to receive this drug. Cardiovascular morbidity, cerebrovascular morbidity are clearly a problem. Interestingly enough, with this amount of bulky mediastinal disease, there were very few hemorrhagic issues seen in this trial, whereas in lung cancer, the minute there's mediastinal involvement or contiguity to large vessels, there is a significant risk for hemorrhagic morbidity and mortality. Not seen in this trial, though. So indeed, the control arm in this study had a much better result than what we're used to seeing. If you remember, the Vogelzang study had a control arm with platinum alone of about 9 months. In this study, and the treatment arm with pemetrexed and cisplatin had a survival of about 12 months. Here, the control arm with just platinum and pemetrexed had a survival of nearly 16 months. Now, we're not quite sure why that is. Is it that we're now caring for these patients better than we were 13 years ago? Is it that perhaps the population here was a lot younger than the population in the Vogelzang trial? The median age in Vogelzang was over 70. The median age in this trial was about 65. So clearly, this is an important trial. It does make bevacizumab an agent to be considered, but it doesn't, in my mind, establish it absolutely as a panacea for all patients. So a dozen years later, we have not really gone that far beyond the backbone. The response rates are still around 25%. The median survival is still around 12 months to 18 months if you have a particularly more active companion. The 5-year survival is still well below 5%. And again, bevacizumab is not applicable to the whole mesothelioma world. All right, that's a very important point to be made. So what's even more daunting is that we still don't have a decent second-line approach for patients once they progress through the pemetrexed platinum backbone. So what's next? So we're entering an age of, a golden age of immunotherapy. There's been, through the FDA approval of a number of molecules in diseases like melanoma and non-small cell lung cancer, and now in bladder cancers, we actually have quite a lot of molecules to play with. And there really have been some new understanding of the tumor identity and the way the tumor sort of shields itself from the host immune system. All of this leads to exciting new possibilities. So very briefly, I'm going to recapitulate the efforts of titans in the field of tumor immunobiology in a fairly simplistic cartoon, but I think it does illustrate a little bit what we're trying to talk about and target. So you have a tumor that's there, and this tumor has a life cycle just like normal cells as well, and a number of these cells are going to die, whether they die of their own volition through senescence or whatever, or they die through other body factors. The result is that you're going to be releasing cancer cell antigens. These antigens are going to be taken up by dendritic cells and processed inside these dendritic cells to turn these dendritic cells into antigen-presenting cells. These cells are going to translate to the lymph nodes, where they're going to expose a whole population of T cells to the antigens that they've learned to identify from the tumor. Once in that compartment, T cells are exposed and sort of learn how to recognize these antigens. And when I explain this to patients, I usually tell them it's akin to giving a dog a scent and sending it on a hunting job. These T cells are then going to translate and traffic to the tumor through circulatory system, usually blood vessels, but also they can do so through lymphatics. And once they get to the site, they have to exfiltrate these structures and get into the tumor itself, where they can hopefully exert their activity and end up killing cancer cells. Obviously, this is a process that has quite a lot of checkpoints and regulatory mechanisms. As you can see, in green are a number of stimulatory factors. In red, a number of stimulating factors. There's several areas that we're particularly interested. CTLA-4 is an area that is particularly interesting at the level of the lymph node, and it is basically active in the expansion of that T cell population that now has an idea of what to look for. And then the PD-1, PD-L1 axis is more a tumor site issue where the activated lymphocytes can be turned off through an interaction with molecules that target these receptors, and explains a little bit why it is important to look for the presence of PD-L1 in tumors to see whether they could potentially be targetable with some of the new agents that go in that direction. Rafael Bueno published a very interesting article in Nature this year, basically looking at the expression of mutations in a number of tumor cell types. And clearly in the yellow box, you can see mesothelioma is at an end of that spectrum that is less immunogenic. This is very important because in general, the more immunogenic a tumor is, the more likely it is to respond to some of these agents that target the immune system. And in particular, you have here a number of lung cancer variations and head and neck cancers, which are, if you will, environmentally caused cancers to a certain extent through the use of tobacco. There's a great deal of mutagenesis that happens from the 500 plus or more carcinogens in tobacco smoke that actually make these tumors a lot more visible to the immune system. Even in lung cancer, when you have patients who have lung cancer who are never smokers, their response to these interventions is much less robust, if you will, than those patients who have actually developed lung cancer through smoking. Mesothelioma is an environmentally caused cancer with asbestos, but the mutagenicity of asbestos is much more complicated and doesn't yield the same amount of mutations, if you will, than the other very complex biochemical mutagens. When you look at the PD-L1 expression with mesothelioma, looking at a number of different retrospective analyses, suffice it to say that there is PD-L1 expression in mesothelioma, and more interesting, there is a greater PD-L1 expression in sarcomatoid mesothelioma, which is going to be interesting for future therapeutic interventions. And PD-L1 expression correlates very well with a poor outcome. The more PD-L1 expression you have, green line here, the worse the outcome is for patients. So here are some initial efforts at targeting the PD-1, PD-L1 axis, and I believe Dr. Sturman is going to cover that as well in more detail. This was a trial that was presented by one of his colleagues, Dr. Ali, Evan Ali from University of Pennsylvania. This was Keynote 28, which was a basket trial. This is a trial design that's actually very interesting. You end up accruing patients with very different indications in sort of unique groups. And Keynote 28 was one of the first trials to have a pure mesothelioma group, which is where those patients were treated. We actually participated in this study and saw some very interesting activity. So the patients had their usual mesothelioma presentation. They needed to have a good performance status. They needed to have measurable disease. And for this particular study, they needed to have sent in tissue to assess for the presence of PD-L1. It did not require heavy presence. It just required PD-L1 positivity. So this is what you look for on the tumor cells. And these patients were treated with a pretty hefty dose of pembrolizumab. Now we're using a little bit less than that. And those patients who had a response continued to treat for up to 24 months or until progression or the development of intolerable toxicity. Those who had confirmed progression stopped. And classic mesothelioma population, median age a little younger perhaps than what we used to see, but around 65. Overwhelmingly male, overwhelmingly Caucasian, excellent performance status, overwhelmingly epithelioid with few sarcomatoid and biphasic. And this was a pretty heavily pretreated. All of them had some kind of cytotoxic therapy prior to starting. This is the response assessment using modified RECIST, which is a technique that is especially designed for mesothelioma assessment. When you use conventional radiologic techniques, it's a lot harder to figure things out, but this modified RECIST allows mesothelioma clinical trials to speak the same language. Anyway, using this technique, about 60% of the patients were on this side of the waterfall plot. In a waterfall plot, you want to see decline, which is why these are negative percentages. You want to see the tumor get into negative percentage points, and the more people on this side of this black line, the better off you are. Here in this is called a swimmer's lane plot. Really looks at the duration of the response, and obviously the longer the line, the better the duration. But this is a very healthy swimmer's plot for a first attempt at immunotherapy. And median survival curve, as you can see, median survival was about, median disease-free survival was about 6 months. Not perfect, but certainly a very good signal. What was actually very surprising in this study was that the PD-L1 expression was absolutely not associated with the response. People with low expression responded, people with higher expression responded. There didn't seem to be a clear-cut relationship. Now, this may be because this was a small trial. But this is a signal that warrants quite a lot more interest. This is a patient who has pure sarcomatoid mesothelioma. This is one of my patients with a fairly large tumor over here between these arrows. And after 3 or 4 infusions of pembrolizumab, this area is not there, and I believe this big conglomerate may be reduced to just this. About a year and a half later, this gentleman is still receiving pembrolizumab and is doing actually quite well. He really has no symptoms attributable to the meso. His only problem is that he's developed toxicity from the pembrolizumab and had to go on a fairly long break for about 2 or 3 months due to the development of very significant skin toxicity. It's a very interesting manifestation. He has to wear a lot of gloves now because his hands are very scaly from the pembrolizumab. Looking at other continuing efforts in there, these are the 3 studies so far. This is actually a second study that was done with nivolumab, which is a very similar molecule to pembrolizumab. Pembrolizumab is made by Merck. Nivolumab is made by Bristol Myers, so competing molecules. This was a European study that is still ongoing. Again, you're seeing similar partial response, similar disease control rate. These are probably not going to be very different over time. Here is a different molecule. Both pembrolizumab and nivolumab target the PD-1 receptor, which is located on the surface of the T cells. This molecule, avelumab, targets the PD-L1 receptor, which is more likely to be located on the surface of the tumor cells. So, obviously it's going to have the same, a similar effect. It's just targeting the other side of the bridge, so to speak, and trying to hit the receptor that way. What may be different is that because you're targeting the tumor itself, you may be developing an antibody-dependent cytotoxic effect. Once you hit a receptor on a cell, and it can trigger other responses from the immune system, which can kill the cell just because you bind an antibody. So this is maybe an effect that is actually important for the future. And this molecule, avelumab, has had some activity demonstrated in lung cancer and a number of other carcinomas. So the design was very similar. This was also a basket trial. It had a little bit more patients, 53, but similar eligibility criteria. The dosing was what had been determined from expanded studies, expanded access, not expanded access, expansion phases of phase 1 studies, looking at response, safety, progression-free survival, and the expression of the PD-L1 marker in the tumor tissue. And over here, the results were a little bit less encouraging than they were, but still a positive waterfall plot nonetheless, which I'll show you in a minute. There were 5 clear partial response here. Their swimmer's plot measured in weeks. And over here, you'll see the waterfall plot. There's obviously a lot more patients on the not so good side of the waterfall plot, but some very deep responses here on this side of the waterfall plot. And this is something we call a spider plot, which gives you an idea of the time to the response and how long the response lasts. Below this line is actually what we define as a radiographic response. Under this line is what we consider stable disease in the middle. So you can see that there's a lot of green, and even some green turning into orange fairly late in the game. So these patients are deriving clearly a benefit. Even though radiographically they're not necessarily going down, they are deriving a significant benefit. These slides, by the way, were the slides that Rafid Hassan presented at ASCO. Here too, the progression-free survival did not seem to depend on PD-L1 expression, which was, again, a little bit surprising and is something that warrants further investigation in the future. So when you put all 3 studies together in one table, you can see that the effect, there is clearly an effect, but we're just not quite there yet. A minority of patients are responding rather than a majority, even though on paper we should see a lot more activity. Looking at a different target, so we've targeted with the PD-L1 axis approach, we're targeting things that are happening in the tumor and that may be driven directly by the tumor. By targeting CTLA-4, we're targeting things that are happening perhaps a little bit away from the tumor. They may still be influenced by the tumor, but they're happening more in the lymphocyte, lymph node reservoir rather than the actual tumor site itself. Tremelimumab is an anti-CTLA-4 molecule, very similar to ipilimumab, which was approved for mesothelioma some 4 or 5 years ago. It was, in fact, the first immune-targeting therapy approved for a cancer indication in a really, really long time. Tremelimumab is made by a different company than ipilimumab. And in a couple of small phase 1 studies done in Italy in particular, we saw that you could get some very nice overall survival in patients who had been heavily pretreated before. Almost 50% survived a year when this is a population that doesn't really have a second line option. It's nice to see that you can prolong survival with this approach. So these two trials really suggested that it would be worth testing this on a larger scale trial in a randomized fashion. And this is the DETERMINE study that Dr. Kindler presented at ASCO, a very large study, 571 patients. What was dramatic about this study was how quickly it accrued. Normally, a 571 patient study in lung cancer would take probably 3 to 5 years to accrue. This study in mesothelioma, which is 100 times less common than lung cancer, this study accrued in 18 months, which was really fantastic. It was a double-blind study. It was a 2-to-1 randomization. It was double-blind, but because of the side effect profile of the drug, you knew very quickly if your patient was actually getting active drug. It does cause some side effects. This study was open to peritoneal disease as well. And patients were randomized to getting tremelimumab every 4 weeks for 7 doses, then a maintenance of every 12 weeks, or placebo IV. And the primary endpoint was overall survival. So it wasn't progression-free survival, which sometimes the FDA frowns upon. And here's the patient population, very similar to what we've been talking about again, mid to late 60s, mostly epithelioid, advanced stage for the most part, at least in second line. By definition, these patients had to have seen some chemotherapy before. Some of them had more than one regime. And then virtually everybody had seen prior pemetrexed. And everybody had a decent performance status. This survival curve, as you can see, has really no significant splay in it. And the hazard ratio of 0.92 was really not statistically significant. Again, this was a little bit disappointing, but it may have to do with CTLA-4 not being quite as good a target by itself as PD-1. So in second, third line, this was not effective. The safety data that we saw, the safety signals in this study were consistent with what we would have expected with tremelimumab. We didn't see anything more than what we would have expected. But what was really remarkable is that if you have an exciting concept and an exciting study, you can accrue to it very, very fast, even in an orphan disease like mesothelioma that has not as many patients to draw upon. So how are perhaps tumors defeating some of our efforts? Well, one of the problems may have to do with the generation of insufficient number of T cells, and this is a problem at this level in this compartment. Another possibility is that even though you generate some cells, not enough of them make it to where they're needed. And finally, once they get there, and this is the whole PD-1, PD-L1 story, the T cells are inhibited inside the tumor microenvironment. Not only can the tumor do that, but there's a number of cells that are modified by the tumor that can actually lead to some inhibitory signals. And you can see that at this level, the list of stimulants is much less than the list of inhibitors. So since we've identified a number of these possibilities, there is a tremendous amount of work ongoing to try to optimize what we're doing with these molecules. And what I've shown you are very crude, very early efforts to try to get at these questions. Another possibility is to target this mesothelin receptor, which is preferentially expressed on mesothelioma cells. Dr. Olewski talked to you a lot about mesothelin directed monoclonal antibody efforts. Over here, I'm going to talk to you about this mesothelin vaccine with CRS-207, which is a modified listeria. It's modified in the removal of 2 genes, which account for some of the nastiness that listeria does to people. Listeria was a very important pathogen at the turn of the century. In fact, Listerine was kind of developed to try to fight listeriosis. And every once in a while, it raises its ugly head in food preparation. There was a listeria outbreak not that long ago in commercial salad preparations, and a few years before that in Jalisco cheese. And when people consume these tainted products, they can actually get pretty sick. And part of that is because listeria will invade, and this is actually a very nice little representation of what listeria does. It invades the cells, and then it invades other cells. The red listeria here are the wild-type listeria, whereas the blue ones are the CRS-207 modified listeria. So you can see that the red ones are kind of going all over the place and even trying to get inside an adjacent cells, whereas the blue ones are actually staying very, very put. This is an actual micrograph from the company that produces this vaccine. The design of the study was fairly straightforward. Patients, once they met eligibility criteria and started treatment, received 2 doses of listeria administered intravenously 2 weeks apart. And these patients come into the infusion center. They get their listeria infusion. They usually get very significant rigors. They shake quite a bit. And usually these rigors are well mitigated by giving a little bit of Demerol. Mostly they have an unpleasant day with fatigue, some nausea, and those rigors. But usually by the 3rd day, which is when we see them, they're actually doing quite well. Once they do their first 2 vaccinations, they go on to receive 6 cycles, up to 6 cycles of pemetrexed cisplatin with CT evaluations every other cycle to make sure that people are still responding to treatment. Once they make it to the 6th cycle, then they receive another 2 boosts of vaccine. And if they still haven't progressed by then, they go on to receive maintenance dose of vaccine every 8 weeks. So we see them back, and we scan them every 8 weeks to ensure that they're continuing to respond. Now, the protocol was modified with the addition of 1 dose of cyclophosphamide at low dose, at 200 milligrams per meter square, which is not a very big dose of cyclophosphamide, administered 1 day before each of these vaccines here, and with the boost. The purpose of this pre-dosing with cyclophosphamide is to try to perhaps neutralize the T regulatory cell compartment. These are T cells that actually blunt the effect of the immune response, and trying to see if we can get them out of it. So that cohort of patients is still ongoing. It's met all of its accruals, but quite a few patients are still being treated, which is very exciting. So again, this population was a little bit older than what we saw in the other trials that I showed you with 71, which means that we treated people as old as 82. And again, mostly males, mostly Caucasians, good performance status. 1 patient snuck in here with peritoneal. This is really a strictly pleural mesothelioma study. And then the majority of these patients have epithelial. A few have biphasic, but there's a requirement in the study that if they have biphasic component, they should have less than 50% sarcomatoid, because sarcomatoid mesothelioma does not really express mesothelin very well. So there's actually some justification behind that exclusion. Here are some of the adverse events. This was extremely well tolerated. Most of these events, the grade 3 events, really have to do with the fever going high and the chills and rigors being a little bit more debilitating at the time of administration. Once the patient comes back to clinic, either 24 hours or 48 hours after the administration, there really isn't any more symptomatology to speak of. So very, very well tolerated. And most importantly, no infectious complications. We didn't see any patients have persistent listeriosis. In the whole CRS-207 program, which included a very large effort in pancreatic cancer, there's only been one documented episode of continuing listeria presence in the body several days after the infusion, and this is in a patient who received the listeria against protocol recommendations through a chest port. So the chest port got colonized and allowed for seeding of the stream. When you give the listeria peripherally, there's absolutely no problems with contamination and colonization. Even if the patient still has a port, they don't get contaminated from the peripheral administration. This is the kind of waterfall plot you want to see. Very little going up and most everything going down. So this had a 60% response rate, stable disease 35% for a disease control rate of 94%. This is good stuff. We like that a lot. And this is really not what you expect to see from pemetrexed alone. This is the spider graph. You can see that there's very few dots above the stabilization line and quite a few lots below the response line. This is really also the kind of spider plot you want to see. And here are some very long responses. In all of the other swimmers plots that I've shown you, this axis was weeks. Here we're talking about months. So the duration is actually, the response is actually a very durable and very effective response. So this was a well-tolerated agent. It worked very well with chemotherapy. It achieved a more than 90% disease control rate. The results are being confirmed in the second cohort that we're doing with the cyclophosphamide pretreatment. Future duration, there is a phase 3 global trial that's been planned. And interestingly, to answer your question, that trial actually allowed the use of bevacizumab in control and just asked sites to sort of to declare whether that patient was going to get it and stick to it. So you couldn't just like in the middle of it add bevacizumab if you felt like it. The trial is on hold due to the negative results in pancreatic cancer, which is a very poor immunogenic cancer. So the company is not a huge company, and they're a little bit, they sobered up a little bit after the results for the pancreas study. So things are being discussed what to do next. But one clear direction that is going to be explored is combining CRS-207 with PD-1, PD-L1 axis drugs. And that's actually a study that I'm very much looking for. That's going to be a very exciting possibility. So clearly, PD-L1 is very much expressed in mesothelioma, but most patients don't respond to this. And we don't really, at this point, have good predictors on how to raise the response from chemotherapy as high as we can get it. Chemotherapy itself can change the visibility of the tumor by causing the presentation of what's called neoepitopes and neoantigens. It may be that combining chemotherapy with these agents is going to be one of the possibilities. So there's a number of studies that are being planned. Here's one that combines the PEMCIS backbone with one of the anti-PD-L1 antibodies. Here, combining an anti-PD-1 with an anti-CTLA-4 also does make sense, and that's actually a big study that we're participating in. It's going to be opened in just a few weeks. Here's another CTLA-4 PD-1 study, and then a number of different options. So Immunotherapy approaches can be effective in mesothelioma. At this point, we're at really at the early discovery stage and look to see a lot of efforts in that arena in the next few years. It's going to really drive the next decade of research in mesothelioma. We really need to identify relevant biomarkers so that we can enhance not only the effectiveness of the approach, but really select people who are most likely to benefit from this. And then obviously we need to keep moving forward and develop new strategies to optimize these results.